want to continue on with this slide for just a minute, just to talk about some of the other consequences associated with elimination and some of the reasons why people have problems with constipation. I mentioned skin breakdown when under urinary elimination, but the same holds true for bowel elimination. Or if somebody has incontinence, they could have skin breakdown. You could have falls associated with urgency or needing to go to the restroom. Again, social, lifestyle, and relationship consequences when someone has incontinence. And then people can get depressed or withdraw whenever they are having issues where they can't have that independence, and it's embarrassing for them as well. Okay. Other things that we need to be looking at in relation to talking not really about this slide, but in relation to urinary elimination, is that individuals with urinary retention can have pain, which is associated with a bladder infection. And if individuals continue to have, say, urinary retention, they may end up with urinary reflux and renal atrophy, which could inadvertently lead to renal failure or their kidneys not working at all. When someone's having bowel elimination problems, we need to be looking for pain, looking at whether they have a loss of appetite, nausea, or vomiting, and some other things. I talked before the end of the last presentation about assessment. Our job as nurses is to, especially after surgeries, every time we go in, to assess when the patient's bowel patterns. If they've had surgery, we're looking at bowel sounds and return of bowel sounds, because that's important, because if they don't have return of bowel sounds, then they could have a paralyzed bowel, and which would lead to diminished elimination. It can eventually lead to complications such as a ruptured colon. Okay. So now we're going to take a look at the risk factors that place individuals at risk for problems with elimination. And in your book, it talks extensively about this. So when we look at age-related potential differences and potential complications is important, because we want to look at this across the lifespan. Infants and toddlers and children, they're born with that lack of control. Okay, usually about 18 to 24 months is when they start to recognize that they have that urge to urinate or to defecate, which means to have a bowel movement. Toilet training usually starts to make them aware and helps them become conscious of the bowel and bladder functions. And this occurs anytime between around the ages of 2 and 3, sometimes earlier, sometimes a little later, especially with boys. With my boys, they were a little over the age of 3 before they were truly potty trained. With pregnant women, as far as that risk of that age group, the fetus grows. There's going to be increased pressure on the bladder, an increased urge to urinate, and larger volumes of urine due to larger blood volume during the gestation or the pregnancy. Okay, and then things like prenatal vitamins can lead to constipation for women that are pregnant. So you'll often see women on stool softeners when they're pregnant. Older adults, there's going to be physiological changes that can affect their elimination. By the time they reach age 80, their renal blood flow, which means the blood that goes to the kidneys that gives it the oxygen so that we can have great or good urinary output, it diminishes down to 600 milliliters an hour. So you'll start to see some diminished kidney function. The kidneys lose up to 50% of the nephrons, which is what we need to help to create the urine and to filter the urine. Which makes these patients susceptible to fluid and electrolyte imbalances, meaning that, sometimes they may have too much fluid, sometimes their kidneys will hold on to the urine and their urinary output will diminish. As we get a little bit older, you'll start to see urine volume decrease and have individuals have urinary frequency. They have weakened urethra muscles. And so they have an increased risk for incontinence, okay? Also, as they get older in regards to bowels, the bowels may start to, the intestines will start to atrophy. So you'll see atrophy of the smooth muscle. decreased mucus secretions, which will lead to reduced tone of the internal and external sphincters, reduced sensation, and which leads to incontinence or constipation. So there's a lot of different risk factors that can occur. Also, what you'll see, men are more likely to experience hyperplasia of the prostate, which will increase the urinary frequency and retention. They're not going to be able to empty their bladders as well. You'll see pelvic floor weakening in women. A lot of times medications such as diuretics can cause an increased frequency and urgency and cause incontinent episodes. Individual causes can also occur. Sometimes we can have trauma to the brain or the spinal cord where messages cannot be sent to that area to just tell yourself, tell your bladder that it needs to urinate. So you start to lose those voluntary aspects of the brain at times. So other things that can lead to retention or constipation, my words are getting twisted. Retention and or constipation could be altered mobility. Cognitive impairment we've talked about, not really sensing or knowing, being very confused. Immunological impairment and an infection that can also lead to problems, such as when somebody has diarrhea or somebody has a urinary tract infection. Okay. In your book, it talks about the bowel, and 8% to 18 million Americans have acute neurological injury or pregnancy changes with development of advancing age. Excessive use of laxatives can cause and can alter and fool the bowel. What happens is the bowel gets used to the laxatives, and then once we don't take the laxatives, it will not contract like it needs to. Cognitive impairment, other individuals with multiple medications, excessive amounts of caffeine can cause urinary frequency incontinence, and limitations to the toilet, inability to get to the toilet. You're going to learn at one point about other disease processes with the bowel, such as IBS or irritable bowel syndrome, chronic or Crohn's disease, people with food allergies that cause severe diarrhea. Some people can have constipation. It can usually go either way. Or intolerance such as celiac disease, where they can't have wheat, rye, or barley. Congenital defects as well. I mentioned my congenital defect with my urinary system when I was growing up. I had 2 ureters on both instead of 1, which created reflux. Diabetes is another disease process that you're going to learn that it can affect people when they have diabetes and their sugar's high. They can have increased urinary output. It can also lead to reduced peristalsis in the bowel. Other conditions that can affect urinary retention and urinary and bowel retention would be CVAs, or cerebral vascular accidents, where the individual's lost part of that functioning and is paralyzed to one side or the other. Diabetic neuropathy, where the nerves are affected. Okay, it can cause and create problems. Dementia, which is cognition problems. Other things that urinary calculi can cause retention, meaning urinary stones or kidney stones, okay, because the urine can't flow past them. BPH, which is benign prostatic hypertrophy, which is the prostate is enlarged. Acute infections and chronic infections as well, such as acute cystitis, which is bladder infection, which could lead eventually to if it's not treated, to pyelonephritis. Individuals can have acute, which means really quickly. Anything that's less than 6 months is considered acute, versus chronic is something that continues to happen over and over again. Okay, I think I've mentioned this before about congenital defects and the defects of the spinal cord that can affect the bladder. So we're going to need to recognize individuals that have this problem. So some of the things we're going to do, and I talked about this in the lab as well, as the different types of tests that we can do. With laboratory tests, we can do a urinalysis, and I mentioned a clean catch midstream, or we can get a catheterization clean specimen if the patient is incontinent. So urinalysis is going to tell us whether they have blood, bacteria, white blood cells, leukocytes in it. and it's going to tell us if they have that urinary tract infection. So they may do the urinalysis, and if it comes back where that has blood, bacteria, things like that, then they may do a culture of the urinalysis. Blood urea nitrogen and creatinine, you're going to look at these labs in association. If BUN is elevated, that one has to do with dehydration. If you see a ratio elevation, meaning they're both going up, the blood urea nitrogen is going up and the creatinine is going up, then we could have some kidney involvement as well. Okay, occult blood, this is our guaiac blood sample that I spoke about in the lab, that that individuals could be asked to do occult blood to check for microscopic blood, which could be an indicator of colon cancer. Radiographic tests, they could do x-rays looking to see if the person has got a lot of air or a lot of stool in the bowel. CAT scans, magnetic resonance imaging to detect the presence of intestinal tumors, congenital abnormalities, or kidney stones. If they suspect a kidney stone, a lot of times they will do a CAT scan. They can go in and do direct observation and do tests such as colonoscopy, cystoscopy, and uroscopy. Colonoscopy is the colon. They're going to go up with a scope. Cysto is they're going into the bladder. Anytime you hear the word cysto, that means bladder. Uro, they're going up further, up into the kidneys and those areas to look for things. They're looking for polyps, cancer, inflammatory conditions, especially in the bowel. They're looking for whether somebody has Crohn's, whether they have cancer cells or something that's suspicious. Polyps is typically what they're going to be looking for, which a lot of times they'll deem them or call them precancerous cells. They may do an angiogram to go up and look at the renal flow and as well as looking at the renal artery. If they have a narrowing in the renal artery, they may need to put a renal stent in. Other tests that you may see done occasionally is bladder stress testing and urine flow studies. This is what test that they're going to do to evaluate urinary elimination, see if the musculature is working properly in that area. All right, you've already been through the assessment course, so you should review that as far as how to assess the abdomen and urine and things like that. Like I said, you're currently in it, but I'm pretty sure you've had that already. Okay. Clinical management of individuals with elimination problems. I'm going to actually leave off right here and start and hopefully finish up with a lecture number 3 on this.